Muchas gracias para todo. Gracias Nelson por la invitación para presentar aquí. And thank you to Ariel for wanting me to do this in English. It'll make it a little easier for me. But I was all ready and prepared, I want you to know. So, practicar todo en español. Okay. So I think it's important that we have this conversation, and I think it's important to understand that there's perspective, and we both have perspectives on global bariatric tourism. So I'm going to talk today about the position statement by the ASMBS, and Ariel only showed one slide, thank you, because otherwise it would have been, my job would have been finished. And I'm going to talk a little bit about global healthcare and the positions of other societies in the United States as well that the ASMBS has mirrored a bit of their statement after. No disclosures. I think this is one of the things that I want to say to the Mexican College is, and I think it's amazing that we're having this conversation today, is be brave enough to start a conversation that matters. Because I think this is the one thing that has been difficult, and the perspective is that the surgeons in the United States only see a very small fraction of the patients who come back when we see a complication. It's rare that we see a patient who's had a good outcome because they're doing well. They don't see us then. And that it's like the GI, our gastroenterologists, their same colleagues, they rarely see someone who's had a successful reflux surgery because they don't come back to them. So thank you for having that conversation with us. Just a little bit, obesity, 650 million suffering from obesity worldwide, 160 million suffering from obesity in the United States. As you've seen on some slides we presented yesterday, we've had 224,000 bariatric surgeries back in 2017. This question mark, I was unsure, but I heard yesterday that in Tijuana alone, you have about 50,000 cases per year, if that was correct. So some of the numbers were a little hard to get, but that tells us that there's a lot going on here, and I've heard from Lisa and Ariel as well. In the United States, there are barriers to getting bariatric surgery. Only 22 states in the United States actually cover bariatric surgery in the state plans. Many insurers actually have exclusions specific to bariatric surgery. And even if they do cover it, in some cases, the costs of the deductible are still far higher than actually having the surgery paid out of pocket out of the states. And our cash pricing in the United States tends to be expensive. So there are obviously leading medical organizations, the American Medical Association, the American College of Surgeons, the Centers for Disease Control, and the ASMBS. And I'm just going to touch briefly on these. I'm not going to read through all of this, but the highlights are that every one of them states that medical care outside the U.S. has to be voluntary. None of the organizations support a financial incentive or disincentive to force a patient out of the United States into another country. And even, in some cases, you'll see even domestic medical tourism. The American Medical Association also has an ethics statement to physicians who have patients seeking care outside the United States. And that is letting them know that have a good conversation with the patient and help them make an informed decision about where they will have their care if they can't have it in the United States. The American College of Surgeons, of course, is one of our sister societies. They want and encourage patients to seek care of the highest quality. And I think that's what we all want. We all want our patients to get the highest quality care. I think it's important, the ACS, as you see in red, they seek care at healthcare institutions that have met standards for accreditation. We've had 2 talks now in front of me that talked about accreditation, and that's important. It talks about quality, protocols, safety. The Joint Commission International is one such example. I know there are other international examples. And the other thing is we want to encourage patients to seek care from certified specialists, bariatric surgeons who are certified, and anesthesiologists who are certified in their specialties. A real other critical component is telling them to obtain their medical records so when they come home, we have an understanding of what was done during their entire workup. And for sure, the American College of Surgeons opposes imposition of provisions on mandatory referral by patients to insurers and healthcare institutions outside the U.S. So the Centers for Disease Control takes it a little farther, and their concern specifically is that going to different areas in the world, you're exposed to endemic bacterial infections that are common in those areas but may be uncommon from where we're coming from. And I know that we've had a discussion that happened recently here in Mexico. And flying after surgery can increase the risk for blood clots. So any travel, any long distance travel even not by plane, and can be a problem. And that also is true of domestic medical tourism. So the American Society for Metabolic and Bariatric Surgery published their statement in 2011. It was compiled by the Clinical Issues Committee led by Stacy Bredauer at that time, and they have 5 major recommendations. So the first recommendation is that because of the unique characteristics of the bariatric patient, potential for major early and late complications, the specific follow-up requirements are different for bariatric patients, and then the chronic nature of obesity, having extensive travel should be discouraged because there are other complications, unless you can have appropriate continuity and follow-up of the patient, which, as we all know in this room, bariatric surgery is a small part. The surgery is a small part of the care of the patient afterwards. And so that is one of the concerns mentioned in this recommendation. The ASMBS opposes mandatory referral across international borders or long distances by insurance companies. And so to give you a good example, in the United States, Walmart has 3 centers across the United States where they'll send their employees for surgery. That's not something that's supported because, in fact, they're sending them to other areas where they have very good surgeons and programs locally. So again, it's not just an international concern. The ASMBS opposes the creation of financial incentives or disincentives. This is very similar to the American College of Surgeons discussion because we don't want to limit a patient's choices, and that in effect does. And it makes the surgery difficult and then may push a patient to go somewhere where they are incentivized or financially viable for them. So recommendation number 4 from the paper actually has multiple subsets. So we want you to know that the ASMBS recognizes a patient has the right to choose where they get their care, and we completely understand that. And so by doing that, we want to put forward some recommendations for that alone. Again, we talk about accreditation at JCI, Bariatric Centers of Excellence. We encourage the patients to investigate the surgeon's credentials. Ariel just talked about that. I think that's very helpful to understand that there are other ways in which patients can actually understand if the physician is certified and get some understanding of specifically how they're trained. And we encourage that the individual surgeon actually share their outcomes so that the patient knows, right? So I think that's important. Anyone who says they haven't had a complication isn't doing enough surgery. Okay, we all have complications. So to claim that there are 0 complications is not true. So providing outcomes to the patient is important. Patients and their providers should ensure there's follow-up care, including the management of short and long-term complications. Have a plan. It's important. These patients need that short and long-term care. Surgical providers should ensure that all medical records and documentation are available. Okay, and Probably not so much anymore, but at the time it was written, bands were very big, and so we wanted to ensure what type of band was placed and this kind of thing. The patient should have a plan for postoperative follow-up with a qualified local bariatric surgeon. That's going to be hard sometimes, especially across borders. It may be difficult unless there's a plan in place where two practices are working together, especially patients getting band fills. That can be difficult because travel back is difficult, right? Travel back to the surgeon who did the surgery may be hard. And I will tell you this, in the United States, our MBSA QIP data, the one-year follow-up's about 40% at 1 year. So the question mark is, what is the follow-up going to be when someone has to travel several hundred miles? It will probably be lower. We want someone who's going to be able to monitor them for nutritional deficiencies. They should recognize that prolonged traveling after surgery can increase the risk of DVT, pulmonary embolism, and other perioperative complications. Patients should recognize the risks of contracting infectious diseases that may be endemic to the area that they've traveled. And patients should recognize that travel over long distances within a short period could limit the appropriate education as well as the appropriate counseling regarding risks, benefits, and alternatives for surgery. They should also understand that compensation for complications could be difficult or impossible to obtain, and that the legal redress for any mishaps or medical errors is across international boundaries is difficult. And lastly, the fifth recommendation is when a patient who has undergone a bariatric procedure at a distant facility, the ASMBS encourages that all bariatric surgeons present and take care of these patients who are presenting with emergent life-threatening issues, that they will be on call and provide the standard of care for any patient regardless of where they had their surgery. Whether they are followed up for routine or non-emergent is left at the discretion of the bariatric surgeon that's in the local area. One future direction, there was an article published last year in SWORD on a national registry, and maybe that's some way that we can compromise and work together. A national registry would help all the stakeholders, which are the patient, the surgeon providing care wherever they may be, insurance companies, society as a whole, and then the surgeon providing aftercare for everyone. So thank you very much for your time. Gracias por todo. Okay.